Hello everyone, my name is Subutem. I am currently an internal medicine trainee. It's a new core medical trainee. I did my foundation in the West Midlands, and for those of you who don't know, I've started doing these clinical assessment teaching sessions, and Janice has been helping me this year. It's mostly because it's a very strange exam that no one really knew a lot about. And that's why I started doing these sessions and started sharing material for it. So the session today will be on prescribing. Now, this is not everything in the entire world that you should know about prescribing. You should already know a little bit about prescribing. I'm just going to go through the more salient points of everything that you need to know for this particular station in your OSCE exam. Yeah, and at the end, we've got 3 scenarios with increasing difficulty, which we'll go through. Okay, so the medication history and safe prescribing station in the exam. It will appear on your exam. It will appear with 100% certainty. Yeah, like all stations, it's going to be 10 minutes, 1 minute of reading time, and 9 minutes in the actual station doing things. Yeah, I've put this year, it's typically in the clinical area because that's how it was for my exam and the previous year's exams. I don't know what the exam was actually going to be like this year for COVID. Yeah, so if you've read the study guide, the clinic area is kind of like a corridor with rooms on either ends of the corridor. It's a nice big room that you go in, and it's good for the prescribing station because it's nice and quiet. Yeah, the ward area in the exam where you'll do some of the other stations if you're having a face-to-face exam is quite noisy. It's just got like a lot of dividers on it that make up the different stations. Okay, you will have a BNF in the station. Now you'll have 2 types of BNFs. You'll have the book. Don't look at the book at all. Put it in the corner and don't look at it at all. You'll have an iPad on which you can access the BNF, right? Use the iPad, use the electronic BNF. I have no clue how to use the book BNF because it is ancient. No one except pharmacists know how to use the book version of the BNF, okay? You might or you might not have a patient actor. This is again dependent on how the exam will be conducted this year. Okay, the main things you need to know for this station is drugs, obviously, fluids, which can be a bit tricky, and less likely oxygen prescription. Okay, there's also special types of prescriptions. These are called specialized prescriptions, such as warfarin, insulin, and blood transfusions, but these are not normally done on your normal regular drug charts. Blood transfusions and blood products are typically always done in separate to your normal drug charts. Insulin can be done on your drug chart. If they do ask you to prescribe insulin, it will never be to initiate insulin. It will be to transcribe insulin, not prescribe it. Yeah, and I don't know if this year you will be asked to take a medication history, but you should go over a very, very precise medication history. So when you're sitting with someone and you're asking them a set of questions, and you want to prescribe medication for them, what do you need to know from them in order to prescribe that medication? Yeah, what medications are you taking? What drugs are you taking? Make sure you get the name of the medication, so the pharmacological name. If you're taking Metformin and they tell you Staccato, ensure that you do know the pharmacological name, which is Metformin. Yeah. Doses of the medication. How much are you taking? Are you taking 5 milligrams? Are you taking 500 milligrams? Are you taking 10 milligrams? Yeah. How many times a day are you taking it? And how do you take it? Okay. Any liver or kidney problems is really, really important to know about. You must ask this question. What times of the day do you take the medication? Yeah. How many times a day do you take the medication? Are you allergic to anything? And if they say, yes, I'm allergic to penicillin, That's not good enough. You need to elaborate. What happens when you take penicillin? Okay, it could be an anaphylactic reaction, it could be an anaphylactoid reaction, or it could just be a side effect. Nausea and diarrhea when taking penicillin is not an allergic reaction. Okay. Are you taking any other medications, for example, over-the-counter medications or herbal remedies? Many patients take over-the-counter herbal remedies like these essential oils, St. John's wort. So it's very important that you need to ask these questions. Many patients don't think that inhalers or ointments or eye drops or ear drops are actually types of medications. You need to specifically ask this question. Are you taking any eye drops, ear drops, ointments, inhalers? You don't need to ask it in a very long, wound out way. You just ask one sentence, just like this, okay? Everything that you do in this part of the station, you need to be aware of time, okay? Do you drink alcohol? Do you smoke any street drugs or recreational drugs? You don't need to elaborate further. If they tell you, yes, I snort 5 lines of cocaine a day, fine, write it down. You don't need to go into a social history, okay? Diet, exercise, go on. Okay, so for your drugs, yeah, you've got the BNF in front of you, and it is a fantastic resource, but you need to know some basic antibiotics and their doses, okay? It will save you such a lot of time in this exam. I have shared a few PDF files in the Telegram group of the common antibiotic doses and the common interactions. Yeah, you just go through that list and try and learn as much of it as possible. This will really save your time in the exam and prevent you from using the BNF. Is everyone okay with all of that I've said so far? Has anyone got any problems, any questions with the medication history?
No.
Okay. So now we're coming to a bit of a tricky one. Yeah, fluids. I know everyone has a problem with fluids. I had a problem with fluids. People taking the PSAs are having a problem with fluids. This is not a session that's going to teach you everything about fluids from scratch. I would hope that everyone already knows a bit about fluids and fluid prescriptions. The points that I make here today are the most important bits that you need to take away in order to safely prescribe fluids for this section in your exam. Yeah. So your daily fluid requirements are here in the slide. This is also available in the BNF. Okay. In order to prescribe fluids for your patient, you need to know the patient's user needs, and they will never ask you to prescribe fluids without providing this type of information. They usually provide the user needs, they provide weight, they provide urine output, or they provide a fluid balance. Okay, and you should already know if the patient has any medical conditions such as heart failure, liver failure, kidney failure from taking your medication history. Okay, your normal urine output is more than 0.5 moles per kg per hour. This is very much the textbook answer, everything that you see in the textbook. A very easy way to remember this for when you're just looking at that fluid balance in the exam is that a normal healthy person should produce about 1 liter of urine in 24 hours. As a very easy, very simple way to remember this. Okay, if fluids can be resuscitation, it is usually maintenance. So they will usually ask you to prescribe maintenance fluids in the exam. So for your maintenance fluids, what I like to remember is 1 salty and 2 sweet. And what that just means is salty is your normal saline and sweet is your dextrose saline. For the past few years, this has not changed. Yeah, it's always been a bag of normal saline with a bit of potassium in it and 2 bags of dextrose saline or dextrose with a bit of potassium in it as well. Okay, so what I've got here is an appropriate fluid prescription for maintenance fluids for 70 kg patient. This could be post-op with no medical problems, normal urine output and normal user needs. Okay, so you can just say that the potassium in this patient is about 3.9. Okay, but because they're 70 kg, you can go 40 millimolar of KCl and 40 millimolar of KCl. You can also safely go 40 millimolar and 60 millimolar. Okay. This is just a table on your composition of IV fluids. Yeah, you've got your normal saline, your 5% dextrose, which is just dextrose. There's nothing in it except sugar. Your Hartmann solution, which is your Ringer's lactate or your plasma light, and your Gelifusin, forget about it. You're never going to prescribe that.
Which one? Sorry?
Gelifusin. You never ever prescribe colloids. Please don't ever prescribe a colloid.
Okay.
Okay, in the exam or in real life, unless you're like a renal physician or something. So the types of fluids that you're going to be considering, it's only going to be one of three things. Yeah, it's going to be normal saline, it's going to be your dextrose solutions and your dextrose saline, or it's going to be your Hartmann solution. Hartmann's, Ringer's lactate, and plasma light all mean the same thing. Yeah, remember, it's got a teeny tiny dose of KCl in it. It's got 5 millimolar of KCl in it, and you can't add anything to that solution. Okay. So if you're prescribing Hartmann's, it's just Hartmann's. You can't say in the additive section of your fluid prescription plus 40 millimolar KCl. That's not a thing. You can't do that. Okay. But dextrose solutions are very good for maintenance because it provides the patient with a bit of sugar, a bit of glucose. It's also good for treating hyponatremia. Your normal saline standard fluid prescription is very good for maintenance. It can cause hyponatremia and your hypochloremic acidosis, but that's less likely if you're giving it over 8 hours or more. Yeah. Hartmann's and Ringer's lactate solutions, it's very much favored by the surgeons. It's very good for post-op cases or ongoing GI losses like your diarrhea, vomiting. I mean, I've put you don't use it for maintenance, but I've seen it used for maintenance in the exam. Don't use it as a maintenance fluid. Yeah, try and go for normal saline and your dextrose solutions. Colloids, never ever prescribe it. Forget about it. I've just got a little bit here about the types of conditions and the types of fluids that you would consider for each for each condition. So as I've said before, in your post-op and your GI losses patients, dextrose saline is okay. Hartmann's is a very good choice. If the potassium is high, don't supplement. It's much better to repeat your usinase and just take it as it goes. And remember, if your patient is eating and drinking, why are you giving fluids? Unless they're not eating and drinking adequately. Yeah, so if their input a day is very, very low, you'd want to supplement that with some fluids. But if they are eating and drinking like normal, don't give any fluids. Okay. For sepsis usually resuscitation, just bolus your normal saline or your Hartmann solution. For heart failure, it's very, very tricky. I'm in cardiology at the moment, and it's a very delicate balance between your ins and outs, because you want to diurese these heart failure patients as much as possible, but sometimes they can end up with these raging AKIs. Okay, so it's very, very difficult with heart failure, and I don't think that they'll give you a patient with severe left ventricular systolic dysfunction or something like that. Okay, that's a bit much for this exam. Liver failure, don't give normal saline. It can precipitate ascites. In AKI, you don't need to give potassium at all unless you've got an obvious hypokalemia, in which case, why do they have a hypokalemia with AKI? Okay, you need to do more investigations on that. In CKD, be very careful with the amount of fluids that you're giving. Tend to go for longer bags, like 10-hourly, 12-hourly bags of fluid. With your alcohol excess and your poor nutrition patients, give your Pabrinex first. Always give your Pabrinex first. Else the glucose that you give with the dextrose solutions can precipitate Korsakoff syndrome. If you are suspecting someone with a stroke, don't give dextrose, it make things worse. And with your risk of refeeding syndrome, don't give dextrose, okay? Out of all of these, the only thing that I see actually coming out would be your post-op patient, okay? I've just given you some scenarios and the types of fluids that you would consider in each different type of scenario. Any question about this? That was a lot to take in. Okay. Oxygen. Oxygen is a drug. Yeah, it must be prescribed. On every drug chart, you will see an oxygen prescription section. These are the types of oxygen delivery devices. You got your nasal cannula, your max flow rate on this. It can only go up to 4 liters by nasal cannula. Your face masks, your Hudson masks, these are your Venturi masks, which are more, I would say, favored, particularly now with COVID. They come in various colors, which are very, very nice. If someone's on the green one, you need to start panicking a bit while they're on 60% oxygen. Yep, you don't need to know anything about NIV, CPAP, BiPAP, or invasive ventilation. Okay, your target SATs 88, 92 in COPD, 94 to 98 is normal. That 94 to 98 is a textbook normal. In real life, they accept anything 92 and above. Yep. Warfarin, I've not really come across Warfarin being prescribed for any of these stations in the exam, not even transcribing Warfarin. But just a bit about Warfarin as well. There should be a particular section in drug charts for Warfarin prescriptions. So your indication for Warfarin must be there. Yeah, so non-valvular atrial fibrillation, which is not really an indication for Warfarin anymore, or your more likely your metallic valves, put the indication there. Your target INR, so your target range is different from your actual target. Your target is a number and your range is a range, so 2 to 3 with a target of 2.5. Yeah, mechanical heart valves, you need a higher target. It also depends on the type of valve, aortic and mitral, etc., and on the patient's individual risk factors. Duration of Warfarin, it might be 2 weeks, maybe you're bridging them for something, or it could be lifelong. Always check the INR, yeah? For the purposes of the exams, you will state, if you're ever asked a question about Warfarin, do daily INRs until the INR is greater than 2, and ensure that there is low molecular weight heparin cover until that time, and that is your bridging period. Because Warfarin is prothrombotic in the initial phase when you just initiate it, okay? Hematologists will tell you something very different if you ask them about Warfarin. You don't need to know too much about Warfarin, yeah? I've not seen it come out before, and possibly if it does come out, you'll be asked to transcribe it as opposed to initiate it or prescribe it. Okay, blood transfusions and transfusion of blood products is typically also on a separate chart. Again, you need to know the indication. Your HB must be written down. Your past transfusions and or reactions goes on your request form and must be handwritten. So you can't be the printed sticky labels for that. Your request tubes, it must be 2 taken at 2 separate places in the body and at 2 separate times, at least 30 minutes apart. 1 is your group and save, and 1 is the cross match what you're actually requesting. Yeah, that group and save will stay in the lab and will be available on the database in case the patient needs future prescriptions, and your cross match is what you're actually, wanting. You can prescribe a unit of red blood cells 1 to 4 hourly. 4 hourly is the maximum lifespan of the red blood cells. Yeah, for a typically elderly patient, I would go 3 hourly. If it's a very young patient with trauma or something like that, just go 1 hourly. Okay. Request 1 unit at a time. The lab won't release the blood anyway, unless you activate the major hemorrhage protocol or if you're in theaters or something like that. Okay. Before we go on to the scenarios, is there any questions you want to ask me? I know that it's quite a lot to take in, yeah, especially the fluid parts might be a bit confusing. But when you start to do the scenarios and when you start to work through the examples, just ask any questions that you want to ask in the Telegram group. Janice and I are more than happy to answer any questions. Okay, and practice does make perfect for prescribing.
Hello.
Hello?
Hi, I have a question. Say you're prescribing for pneumonia.
Yeah.
Do you have to do the curve 65? Do you have to calculate the, so take the blood pressure and respiratory rate and everything like that?
No, because they're already a patient in the hospital. They're already admitted.
Okay. So that information will be given.
So in the task, they'll tell you where the patient is. You're on the acute medical unit, or you're in admissions, or you're in A&E or something like that. So the patient is most likely going to be admitted anyway. So it's not the purpose of the station or the task to test you on the curve 65. So the purpose of the station is testing on how you prescribe antibiotics for that patient. So they're not going to make it very difficult.
Okay. And say, for example, that they're on some drug and they're also on warfarin. Do you suggest that they reduce the warfarin or stop the warfarin or something like that?
Oh, it depends on the type of drug and the interaction. And that is something you will need to know.
Yeah, so say they're on penicillin or macrolide, and they're also taking a warfarin. Do you explain to them that, okay, yeah, this is interacting and this is dangerous, it can increase your risk of bleeding? And do you stop the warfarin, or what do you do?
So you prescribe it, yeah, you tell them that these two medications can interact with each other, and you tell them that we will monitor your INR and we will increase and decrease your medications as needed.
Okay.
All right, I just got a quick question.
Thank
Oh, sorry. I just got a quick question. So the difference between the NCA and the PLAB2 is that everything is from in the acute scenario. So they're all hospitalized. It's not like PLAB2 where like you can be in GP surgery, you can be, okay. So it's always going to be good. Okay, sorry, thank you.
Also,
the clinical assessment exam is at the level of FY1.
yeah, and
Okay,
okay.
F1s don't go into the community. That's F2 and above.
Yeah, okay, thank you.
As an F1, you're not allowed to do community prescription. So, you know, the green FP10 GP prescriptions, you're not allowed to do that. Or like one of those pink forms, you're not allowed to do that. There's a lot of restrictions on F1 prescribing. So you ask anything in the community is basically just like a hospital prescription.
Right, okay. Yeah, so I'm just going backwards. I did PLAB2 and now coming NCA, it's just trying to get myself.
Don't worry, it's an
Okay, thank you. Thanks.
Okay.
Anything else before we go into the scenarios?
I guess not.
No, everyone's eager to prescribe.
Okay, so I guess we can move on to the scenario. So as you can see, there's a scenario on the screen. So what we'd like everyone to do is, hopefully you've already prepared your drug chart, have it printed or whatever. And shall we give people a few minutes? How long do you need to try?
So I'll say 1 minute to read the scenario, because that's the amount of time you're going to get in the exam, isn't it?
Okay.
And then I won't time restrict you on actually prescribing it. Okay.
Okay. Okay, so I will set the timer to 1 minute. So just let everyone read it. really loud. Okay. All right, 1 minute up. So I'll share the drug chart first, and you guys are free to just tell me like what to put in, because obviously I'm not going to be the person answering this question. Right, let's see. Is it going to work? Okay. Okay, can everybody see the drug chart on the screen? Yes, I can see some noddings. Cool. Okay. What do we do first? Anybody want to answer something?
So I think the first thing you should do is take the medication history. So ask what type of medication they're taking for the hypertension, diabetes, and
I don't know who's talking there. Yeah, okay, go on. Do you want to go for it? So Shah can be our patient, can't you, Shah?
Yeah, I will be a little old Bethany Smith.
Okay, go ahead.
So should I start like from the beginning, or?
Yeah, do what you want. So I will be like your scriber. Okay, so I'll be the one like writing it down. So just tell me what you want to put in each box, and obviously people can come and add in when you're stuck or anything like that. So no pressure.
Okay, so for the history, so I would just like to say, hi, my name is Joanna. I'm one of the junior doctors here, and I've been asked to come and speak to you today. Can I get your name and your age, please?
My name is Bethany Smith, and I'm 89 years old.
Great. How are you today, Bethany?
Oh, not too bad, doctor.
Perfect. So I've been asked to come and speak to you today about some medication and prescribing. So I'd like to start with a little bit about a history of what you're currently taking at the moment. So could you tell me a little bit about some of the medications that you're currently taking right now?
Yeah, I'm taking a tablet for my blood pressure. It's called Ramipril, and I take one 5 milligram tablet every morning.
Okay. And is that the only medication you're currently taking?
No, I also take a white tablet called Metformin, and I take one 500 milligram tablet every morning with my breakfast.
Okay. Any other medications that have been prescribed or even over the counter?
No.
No? Okay. So you have Ramipril, 5 milligrams, and Metformin, 500 milligrams. Okay. And you said you take your Ramipril once a day?
Yes.
Once a day. And is that in the morning?
Yes.
Morning. Okay. And then, sorry, your Metformin, is that in the morning as well?
That's in the morning with my breakfast.
Morning with your breakfast. Okay, perfect. Just kind of stuck here. Okay, so do you have any allergic reactions to any medication?
No, I'm fit and well, doctor.
Fit and well, perfect. Okay, and do you have any kidney or liver problems?
No, I'm fit and well.
Okay, perfect. And are you taking anything like inhalers, ointments, eye drops?
No, nothing.
No. Okay. Do you drink, smoke, or use recreational drugs at all?
No.
Okay, and how is your diet and exercise?
Oh, my diet has been a bit poor at the moment. I think that's the reason I'm in hospital. And I don't
Okay.
really get out that much.
Okay, so we can definitely take a look at that after we're done here and possibly get you in touch with a dietitian to review some things with you. But yeah, so we can get into prescribing now. Honestly, I don't know what to do next. So because I don't think I'm supposed to be doing the whole thing, right? Or just we're stopping at the antibiotic part.
That was really, really good. So you asked me all the questions, and the questions that you asked are all the important things that you need to know from someone. Yeah,
Okay.
you need to know what they're taking, and you know the exact types of medication, what they're taking, and when they're taking it is the most important part. And we asked that, when do you take it? Yeah. So now that you've got your list, you just go onto your drug chart and you
Okay.
go section by section from the top, filling it out.
Okay. Actually, I just have a quick question. For the scenarios when we read it, if it says like this patient has hypertension, diabetes, and whatever, do we go in and say, like, I know that you have hypertension, diabetes, and kind of start from there? Or are we supposed to be asking them what their history is with medication, what they actually have before we get in? Like, should we?
So if it's already given that the patient has hypertension and diabetes, I wouldn't, repeat myself, because all I'm doing is wasting time. I'll just go straight into the medications. What medications are you taking? Because I know that they're taking something, but I also don't want to put words into their mouth.
Okay. And then lastly, if you know what the medication is taken through, like the route, do you ask, or do you just write it down?
I would confirm, yeah, and I would confirm the timing as well. So you take that orally, yes, it's a tablet, and you take that once a day, is that right? And then I'll go from there.
Okay.
Would anybody like to say what you want to write in the drug chart? So we've got the first page here, like the top bit, and then you have the second page. Okay, so should we start from the top? Yeah, I'm not going to write it. I just want someone to tell me, like, so you know what to do. Does that make sense? Because it doesn't. There's no point if I just write it in my own.
Yeah.
Go on.
So
I could just start.
oh, sorry.
Oh no, it's okay. You go ahead.
No, you go.
Someone.
Okay. Well, I was just gonna say we have to fill out like their NHS number, and I don't know if we're gonna have one, but if not, do we just put like random
Yes,
numbers?
you will have all the patient details with you.
Okay.
So you put their NHS number, you put their first name and last name, you put in their date of birth and their weight, which also should be given. And then in this case, she said she's not allergic to anything. So would you write no allergies or just leave it blank?
I would write no allergies, because you have to fill out that box. Okay, there's no allergies. You must put no known drug allergies, or NKDA or something. Or if there's an allergy, you must put the drug or what they're allergic to, and a dash or a bracket and the type of reaction that they get. So that allergy box is a mark that the examiner specifically looks for. You must fill out the allergy box.
Okay.
Okay, so Mrs. Smith, what are you allergic to?
Oh, I don't have any allergies, doctor.
Lovely. Okay, so the date the chart is rewritten, so it's going to be whatever date you take your exam. I'm just going to do that now, and we'll leave the ward and the consultant. Okay, so what do we do next, please? What would you like to write?
No, I don't know if somebody else wanted to go. I didn't want to like overstep.
Yeah, so could I have a go?
Of course.
Yeah, so you just write ramipril, 5 milligrams. Route is PO. You start date, which is the I'm trying to say 5th of September. 2021. Do your signature, print your name, write the indication, which is hypertension, and so she takes it once in the morning, so that'll be like 8 o'clock in the morning. And then you do the next drug, which is metformin. I think she said it's 500 milligrams, right? I'm not sure, I can't remember what she said. So the same thing, so PO, signature, print name, start date. And I've also done, she said she has it with her breakfast. I've also done at 8 o'clock, presumably she has breakfast then. If I have to write anything extra, like with breakfast or something. So that's how it would just fill in regular medications. And then obviously, because she's not drinking adequately, I just prescribe fluids as well. So does anyone else want to, can I carry on with the fluids or?
So where would you put the ramipril and the metformin? Because it says there's one's only medications here, yeah? So make sure you see, look at the heading, and then there's antibiotics, and obviously there's so the prescriptions order. So first of all, obviously fill in her surname, her forename, hospital number, date of birth, and then fill it in the regular medication section. Yep. So the same thing again, 1, 2, 3, 4, and so on, whatever it is. So we have the year, which is like here. So make sure you put in whatever year it is at the moment. Have the day of the month. So let's say it's today, and you have the 5th of the 9th. Okay. So we'll start with Ramipro, and you write it in capital letters. So Ramipro. Okay. And what was the dose that you take, Mrs. Smith? Is it 5 milligrams?
5 milligrams, yeah.
Okay. So we'll go 5 mg, and then route. You can write oral or you can write PO. It really doesn't matter. And the start date would be the date that you're writing the prescription, even though they have started it like previously, obviously, but you are actually starting this prescription now. And then you sign and you write your name, so whatever it is. And then the pharmacy box you leave empty. You don't really need to write a review date for a medication that they have been on already. And the indication is quite important. So indication, it would be hypertension or whatever reason that they're on the medication for. Okay, anything that I'm missing here for this drug, this medication?
Circle the box.
Yeah. So yeah, just circle clock. That's what I said, 8 o'clock in the morning. But yeah, because she takes it once.
So you take it in the so she takes it in the morning. So you would circle 8 o'clock, for example.
Yeah.
Okay. And what happens?
So I just this is just a question because I think Sarishka posted the book about prescribing at a glance. I had a look at it, and it's in terms of the frequency. Usually, I mean, in hospital, the TDS or your QDS, but in that book it said like 8. They actually wrote 8 hourly or 6 hourly. So I just want to ask, like, what do they expect?
So are you talking about transcribing a regular medication when they say 8 hourly on this?
Yes, so basically it's a I mean, if you look at that book, that Prescribing at a Glance, when it says the frequency, usually in hospital drug charts we'll just write TDS or BD or whatever, but in it they'll say they've actually written 12 hourly or like 8 hourly. So I was just wondering, what's the expectation in the exam? Can we just write QDS or TDS or BD or?
No, you have to specify the times. So
yeah, I mean, I understand. Yeah, I understand the times, but you know, it doesn't say here, but actually just in that book, it said like the frequency, and we abbreviate.
I think you're cutting out there. I think I understand your question. So to be safe, I would, excuse me, to be safe, I would go ahead and do 6 hourly or 8 hourly, because it's the same thing anyway. If it's TDS, it's 8 hourly, right? So it's safer if you write 8 hourly. Does that make sense? Like I said, and also with the like route as well. So you can write PO, but again, it's better to write oral. It's just better practice in a sense. They are trying to like phase people out from writing abbreviations and things like that, which isn't great for. You can make mistakes with TDS and BD, but people still do that in hospitals. You're very right. But for exam purposes, to be safe, go and do 8 hourly or 6 hourly or 4 hourly, whatever it is.
Thanks. Yeah, that's great. Thanks a lot.
Okay, so with Ramipro, so we've got the times and things. Anything else anybody wants to add, or you're happy with Ramipro?
I'll just ask a quick question. Is it ever worth using some time to check the dose if it's something that you don't immediately recognize? Do they ever sort of trap you into a patient that has got the dose wrong or doesn't know their dose?
They wouldn't necessarily trap you.
There's no tricks in this exam, no. Okay, if you are unsure about the dose, go to the BNF and look it up, but they will never try to intentionally trick you or trap you with the doses.
So you just take it on trust that the patient will mostly know what their dose is. Yeah.
Yeah. Just for the exam. In real life, you have to double check it, but for the exam, it's straightforward.
Okay, thanks.
They give you a sheet of all the medications. Those are the medications that you need to put on the drug chart. It's simple and straightforward.
Something to add on that as well. You could ask the patient if you brought your prescription in with you. And sometimes they do bring like a scrap of paper, and then it's just easy, you just copy it down. I think in the exam they have been given like the actual prescription as well, so it's something that you can ask them to do. But if you're unsure of the dose, yeah, look it up on the BNF. It will be the same as the one on the BNF, so it's not going to be like 4 milligrams on BNF and the patient's telling you 5. Yeah. Cool. Right, the next medications or regular ones would be, does anybody else want to tell me what to do? No? Okay. So 2021, and I believe you were taking metformin. So the same thing again, yeah. So make sure to write, I would prefer to write it down just as when you're talking to the patient, saves a bit of time. Otherwise you would be scribbling on the side on another piece of paper and then coming back again. You don't have that much time in this station. So just write it down. Even if you don't write the full thing down, just write the name and the dose probably and the time which they're taking. Okay, and then the dose, I believe 500 milligrams was the dose. And then the route, so oral or PO, I'm going to write oral this time just for fun. And then 5 of 9s. You take it with your breakfast, don't you? So 8 o'clock, shall we say? And then 5 of 9. Yep. And then signature again and print name. In my hospital, we write our GMC number, which is exciting, isn't it? And then you have diabetes down here. Okay, anything else anybody wants to ask or add? Unsure of?
Sorry, I just want to ask a question.
Yeah.
Is it possible that the time when the patient takes the medication isn't listed? Like here you have 8, 1, 5, and 10.
Mhm.
So
Yeah.
in an event where it's not listed, yeah. So what do you do then?
So if I get rid of the circle, what you can do is you can just cross this out and you write, let's say they take it at 9, okay? And maybe, I don't know, 8, 6 o'clock or something like this. Does that make sense?
All right. Yeah, thank you.
I've got a question. So as far as I understand, hello?
Yeah, go ahead.
Yeah, so as far as I understand, in this section, we just fill in whatever the information the patient gave us. Is that right? So, and I'm not sure about the dose. So so if patient is not sure about the dose, how would we know? Because even Ramipril, it can be 2.5 up to 10. So we don't, if we check BNF, it wouldn't tell us what dose that particular patient is on. Is it better just to leave it empty if patient doesn't know the dose? Because we can't assume or guess.
No, so they will know. In your exam, they will know. Whereas
They will know.
A&E,
They will tell you the dose.
Yeah.
Okay, so they will give us all the information. We just literally just filling in whatever the patient told us.
Yeah, and it's in the exam. You are being tested on filling in the drug chart. That makes sense. So you're being tested on where to write what and how to write it. Whereas in real life, you have. It's not the case. You have to look up the GP records and all that.
Okay.
Is there a question on the chat?
Yeah, just one more question, please.
Yeah, go ahead.
Regarding the regular prescriptions where you have written 05/09, do we need to continue with the date or we just write it once and that's it?
With the regular prescriptions, you don't need to write a review. If you want, you can do it in 7 days or something like that. But with the regular prescriptions, you don't need to. Okay. The bit that is most important in terms of review date would be antibiotics, because you always need to review your antibiotics. And does anybody know what's the review time for antibiotics? How long?
5 days?
7 days?
48 hours?
Yeah. For hospital prescriptions, 5 days, I think. And, for IV, and for oral, 5 days.
No, 48 hours. for
Oh,
every antibiotic.
Oh, yeah, sorry, yeah.
So we can go up now. Oops, that is stuck. My screen is stuck. Okay, give it a second. Oh, there we go. So there is.
Sorry to interrupt. Could you repeat what you were saying before about the review? I couldn't hear.
Yeah, so with regular medications, so Ramifil, Metformin, anything that the patient has already been taking, you don't necessarily need to write the review date. So if I point it out here, like the review date on the screen, can you see that? You don't need to fill it in because it's not your job to review. Whereas if we go to the antibiotics section, the review date is very important, and we should always put in a review date of 48 hours time, so 2 days basically.
Okay, thank you.
Okay, so the next one is fluids, or is there anything else anybody wants to add whilst we're in this page?
No.
Hello?
Yeah.
Oh, sorry. I just want to ask, would we have to do like controlled drugs? Prescription, no?
Like morphine and things.
Yeah.
I don't
It's
think we will.
controlled drugs like morphine, codeine is not a controlled drug. Morphine, gabapentin, pregabalin, those sorts of things. They're just like any other drug. Prescribe them just the same way. Yeah, there's no difference except when you're dispensing it, and you're not dispensing medications. The pharmacist is.
Yeah, so you don't have a pharmacist like on your back saying you prescribed this bloody morphine wrong. Okay, so if I stop this, I'll bring up the fluids in a sec. Fluids chart. Okay, there we go. That's the fluids. Right, who wants to go?
This is the actual prescribing bit in the scenario. This is what you actually have to do.
So basically she's a 63 kg woman, so she needs 1.5 ml per kilogram per hour. So I think that would be about I think 2,268 milliliters in 24 hours. So I'm going to round that up to about 2.5 liters, right? So that's probably the maintenance fluid that she needs, 2.5 liters in 24 hours. So I mean, what I was thinking is perhaps to give, I know the one salty, 2 sweet, but I was reading that because her sodium is quite high, well, not quite high, it's a little bit high, and her potassium is low. So I might give, I might just half a bag of normal saline and then give 0.8% dextrose saline, 2 liters of those instead, to kind of make sure that she doesn't get more hypernatremic. And I would also prescribe 20 millimoles per liter of potassium in each one of the 1 liter bags.
Okay.
Yeah, you could do that. There's what was the sodium? Was it like 146 or something?
No, the sodium is 151.
It's fine. You can safely give normal saline, but if you want to do dextrose and 500 moles of normal saline, that's absolutely fine as well.
Okay, what are we going for? Infusion fluid, 0.9 normal saline, or?
Yeah, so I was just thinking 0.9% saline, 500 mils. So yeah, and so no additives to that, IV, and then my signature. And then would give I'm not sure about this 0.8% dextrose saline. I think it's got 30 potassium in it, so I was just thinking about to give 2 of that, so 1 liter of 0.8% dextrose saline, 1 liter.
What's 0.8% dextrose?
0.18, sorry. Dextrose saline. Yeah. I think it's got, because I was just looking at the OSCE stop book, that's what it says in there. But, in terms of this one, I think I would give it, it's 8, I would give it 8 hourly.
Okay. What's the second bag?
So dextrose saline, 1 liter, 8 hourly. And to that, I would add 20 millimoles per liter of potassium.
Okay, fine. Yeah, 20 millimoles of potassium.
I've given 8 hourly again.
Mm-hmm.
And I would repeat that bag again, yeah.
Okay. One liter. And would you put the same potassium?
Yeah, the same potassium, yeah.
Okay. Hourly?
Yeah.
Yeah, that's perfect. You got it right. That's full marks for this. Absolutely
Can
perfect.
I ask a question? Sorry, I had something very similar, but I mean, hers obviously makes a lot of sense, but I just wanted to know if I wrote what I wrote, if it would be fine or not.
Yeah,
So I had like saying 0.9, like 0.9 normal saline, and then 1 liter as the volume of fluid, and then the additive for that, I would put 40 millimoles of KCl, and then 0.5% dextrose, 1 liter with no additives, and then 0.5 dextrose, like 1 liter, no additives, and all 3 of them would be 8 hourly. I don't know if that.
So you're giving 2.5 liters or 3 liters?
3 liters. I don't.
3, it should be fine. Yeah, it's not a problem. You can go 2.5, you can go 3 liters for this lady. I wouldn't go 4 liters or 5 liters in 24 hours. And if you give 1 or 1.5 liters, that's too little fluids. But I think you can safely give 2.5 to 3 liters for this lady.
Okay.
Yeah, I would stick with the lower end, especially because she's elderly.
She's elderly
and things like that. Okay, I'm seeing lots of confusion in the chat. What's the problem? 8 stars, 8 hourly, yeah. So is it Belen? Okay, what's the question? No?
Hello?
Hi.
Oh, sorry, I just want to ask, this is just for maintenance, isn't it? Fluids?
Yeah.
Yeah, okay, thank you.
You wouldn't resuscitate someone with 3 liters of fluid. So let's just go through this whole thing again.
But she's severely dehydrated. Looks like she's severely dehydrated. So do we need to replace the fluids first before we do maintenance? Because I thought in the maintenance fluids is only once we once we replace the fluids. Because lady looks like she's severely dehydrated. Urea is high. She's confused. She hasn't been drinking. Her urine output is very low. She's severely dehydrated. Is that enough just to give maintenance fluids, or do we need to replace the fluids first?
She's not confused. I wouldn't say she was confused.
She was drowsy or something, lethargic and drowsy. Her urine output severely low, very low, which shows obviously there's a hyper. I think it's very low. I think it's only like 120 mils for the last few days.
Yeah, so I think for the purposes of the station, the point is to prescribe maintenance fluids for this little elderly lady who's not eating and drinking as well as she should. Yeah. I don't think we need to aggressively resuscitate, and that's not the point of this station. If it was a patient or a scenario with sepsis, which is much more likely, then you'll think about doing your bolusing of fluids and things like that. Yeah, or sepsis or trauma patient or things like that. For this scenario, this little old lady is not eating and drinking. You're going to give her slow IV fluids, maintenance fluids, until you figure out what's going on with her. And I think that's appropriate.
And I'm concerned about her urine output. I think it was very low. So I thought we need to do resuscitation fluids, like first to bring her urine output to the normal and then start her on maintenance.
Yeah, well, that's not going to happen immediately, and that's not going to happen overnight. Again, she's a 63 kg, 89-year-old lady. Are you really going to shove fluids into her?
Probably not obviously like 500 mils, maybe start with 250 and go slowly and watch, obviously look for the signs of heart failure, like dyspnea, crackles, and things like this, raise GVP.
I would not. I would prescribe these maintenance fluids and using these. If this was a real patient in the hospital, I would not bolus anything unless she was tanking her blood pressure or something like that.
The reason is also because if you give too much fluids to an elderly person, it just goes in the wrong place. So you end up having like sort of edematous legs and arms, and that's not what you want. Also be mindful about their kidney function. I think the lady's kidney functions wasn't that great as well. So I'm happy to just do the maintenance if it was like a real life patient as well. There was a question about type 2 diabetes. Should we be careful about prescribing dextrose? Dextrose in the 0.18 bag is 0.18. It's fine. And the person needs the glucose to like
it's 50 grams of glucose. If you're giving 2 bags, it's going to be 100 grams of glucose over 24 hours. People with diabetes also need to eat. Okay, all that glucose is doing is going to be preventing starvation ketosis in these types of patients. It is absolutely fine to prescribe solutions with dextrose in patients with diabetes.
Sorry, could you please quickly explain?
Yeah, go on.
Yeah, sorry, could you quickly explain how you came up with 3 liters? Like you have 500 ml, 1 liter and 1 liter. So could you?
Yeah. So I would, like I said, I would rather give 2.5 liters than give more. Yeah. And always top up later.
So we are calculating it according to the fluid requirements for the day. And we're using that calculation, the fluid requirements for 24 hours, and we're calculating against the patient's weight of 63 kgs.
Okay.
So we are guesstimating the approximate amount of fluid that this patient would need in a 24-hour period.
All right.
And again, as well about this patient, is there any reason we can't give it orally or we can't give it NGT tube? Because she's not, like, I don't know, is there any reason she can't drink and we can't give it orally?
Well, she's a little old lady. Yeah. Who's coming from a care home, not eating and drinking as much as she should. You'll see a lot of these patients in hospital. Give them some fluids, and then after that, try and figure out why they're not eating and drinking. Okay? I wouldn't be pushing NG tubes down these patients.
No. Imagine your poor little lady. Like she's like very small. She's 63 kilos, and she's just sitting there in her bed, like clinically dry. You don't want to be shoving 2.5 liters of water down her throat, and also you don't want to be shoving an NG tube down her throat. So the best thing you can do for her, put it in an IV line and let it run. She's going to be sitting there anyway, so put it in a bag. Does that make sense?
Yeah, but I think it's also stop. They say it's if patient can drink or if it's the possibility we can do HGT tube. We should go for that because obviously any cannulation, she will be cannulated for 24 hours on the drip. So there's always risk of infection, and considering she's elderly lady, we don't want any, obviously cannulation always carries a risk. So, and it's always safe if she can drink. Obviously we won't push her to drink 2.5 liters in an hour, so it will be over 24 hours. But
yeah, I think
might be safe.
I think you're thinking too much, and you're kind of detracting from what the scenario has specifically asked you to do and what they're actually testing you on. Cannulas can stay in for 72 hours. It's fine for cannula to stay in 72 hours.
Okay.
So sorry guys, I've just got a question. I can't remember. I'm not sure if I can pronounce her name properly, and I don't want to mess it up. So Sa, if I'm correct, she said this lady can get up to 3,000. Is that correct?
3 liters.
Yeah,
3 liters,
3 liters. Yeah, so if we go by the calculation from the stuff that you put up earlier, so with the 20 mils to 30 mils per kg per 24 hour, for like, if you're doing that calculation, it's going to be about 1,890 or maybe maximum 2,000. So how are we able to give this lady 3 liters?
I would go 2,500, but you can go up to 3 liters if you're prescribing it over 24 hours. Like you can give 1 liter of 8 hours.
Okay, over 24 hours.
Yes, it's over 24 hours.
Okay. Oh, I thought within 24 hours. Okay, that's all right. That's fine. Cheers.
So I think there were some questions about how to do the calculations. So what's like a normal, it was 25 to 30 mils, right? I think. So if I write it down here, so 25, shall we do 25 because she's old, kg per day? So that is around how much for her? How much fluids does she need? No answer.
$1,575.
Okay, so let's say
Sorry.
let's say that much, yeah. So we'll round it up somewhere. Yeah. Okay. Cool. And in terms of, so this is the amount of fluid that she needs. And what about electrolytes? Okay, so we have all sorts of electrolytes, we have sodium and all that stuff. So what you really need is to have a rough idea about each different types of fluids and what their contents are. So sodium chloride has how much content? I don't even remember. So let's see. Composition. So 0.9 sodium chloride has 154 grams of sodium. And I think her sodium was a bit higher as well. So I mean, we could avoid that if you want to, but. So this is 0.9 saline.
Yeah, I think Hartmann has slightly lower sodium, which is 131. So
Yep.
It might be better option in her case because she already has slightly high sodium.
You can do that. Plasmolide is probably the most physiologically similar solution to get. And so we would normally prefer plasmolide, but sodium chloride is fine. Right? It's absolutely. Okay.
Your Hartmann's and Ringer's lactate only have 5 millimolar of potassium. So you won't be meeting this lady's potassium requirements for the day.
No, I give 500 mils Hartmann's and then 1 liter of dextrose saline with 40 millimoles of potassium chloride.
That sounds fine.
Yeah, that's also
fine. Okay, everyone happy with this so far? It takes a while to get used to be fair. Okay. Shall we move on to the next scenario?
I've got a question about these regular prescriptions. So if we need to prescribe any medication, which is not antibiotics and which needs to be taken regularly, or it's very unlikely we will need to prescribe anything for the regular prescription?
Sorry.
So there's in this station is the possibility that we will need to prescribe medication which is a regular prescription. So we've taken the patient history, we wrote down what patient is on at the moment, and will they ask us to prescribe something else? Is the possibility because the condition is not managed properly or something, and we need to prescribe them either substitute or prescribe them another medication which is regular medication.
You could very well be asked to do that, yeah, but it wouldn't be anything sort of start methotrexate or something, which you can't do as an F1, by the way. It wouldn't be anything.
Maybe it might be anti-sickness medications or some pain medications or something like that.
And then in this case, do we need to write the review dates, always review date and the dates on the top? Do we have to fill in for the whole period? Like, let's say if it's for 5 or 7 days, do we need to fill in the whole, the row at the top for the dates?
Let me share my thing again. So if that, so that's a different story. That's not a review date. That is, you stop that at 5 to 7 or 7 days, right? You're not going to review it. You know you're stopping it. So if I show you the drug chart again, so let's say you have, I don't know, give me a name, a medication that you would stop for 5 days, something like that. Yeah, cyclizine, whatever. Just this is an example. Okay, so you have 5th of 9, and you have 6, 7, 8. So 1, 2, 3, 4, 5. Yeah. So you want to stop cyclizine at 5 days. So you draw a line here and then cross it out. So it cannot be prescribed anymore. Does that make sense? So this is not a review date. This is like you stop it.
Oh yeah, I see. Okay, so we just stop it.
Yeah, and if you like, you can obviously write 9 out of 9 if you want, but the important bit is that you cross out the back so that the nurses are not able to sign it, so they can't give it.
Okay.
Okay.
Yeah. Thank you. Yeah. Thanks.
Should we go to the next scenario, please?
Yes. The next scenario is longer.
Wonderful.
So this is a proper history. It's got everything you need to know. Yeah.
You need to share your
screen. So you don't need to ask any questions. You don't need to take the medication history because everything is already here. So just go and prescribe the medications.
Okay, I think we need to share the screen again because we can't see it.
Oh, okay.
Okay, 1 minute to read. Obviously, you get to see the scenario again when you're in the station, but let's pretend you're standing at the door now. 1 minute. Okay, who would like to give this a go? Hands up.
We just write down the normal, his regular medication is his whatever is given in there.
Okay.
Ramipril, I think, metformin.
Okay, right. Stop.
So for the date.
Yep. Okay. So I'll write this down. Hospital NHS number, blah blah blah. What's the name? Mr. Right.
Right. Deacon or something.
Okay.
Just make up the names.
Whatever. Date of birth doesn't really matter for me. Okay. Weight. What's your weight, Mr. Wright?
I don't think I have a weight. Do I have a weight? I put a weight there. I can't see the thing.
Let's go 100. Consultant ward. Okay. Okay. NKDA. Yeah, no known drug allergies. Happy with that. Right. So once only medications. Does anybody want to put anything in this section?
Maybe analgesia because he's got some pain.
Okay. Which one?
Paracetamol.
Okay. Oral?
Paracetamol 500 oral, yes.
Okay. So date requested would be today, yeah, or your exam date, and then the time. And some people just write stat, so immediately, so STAT. You can do that if you wish. You can also write the current time if you wish. And you mentioned paracetamol, so I'm going to write paracetamol down. Okay. Dose?
I think 500 for now.
500, okay. And then oral.
Or
Happy?
just yeah. There is a print name. Should we write our family name? Yes.
Yeah, you can write your full name. You can write whatever you like. Yeah.
And given by not by us, isn't it? It's just going to be nurse in time given or by us.
No, so forget about this. The nurses will do that.
Yep.
Okay. Unless you go and give the medication yourself, but you never do that. Okay. How about antibiotics? What would you like to put in here? Anything?
Yeah, I would give amoxicillin.
Okay.
Amoxicillin, 500 milligrams. So we put today's, we put the year 2021, we put today's date.
Lovely, very good.
And the time, we probably, it's 8 hours, so we probably give it, I don't know, every 8 hours. We actually need to write the time, isn't it?
Yeah, so let's go
8 and then 4, maybe,
yeah.
Or something like this, yeah.
Yeah, or you can cross this out if you choose like 8 and then if you want to do like 2 o'clock.
2 o'clock, yeah.
It's fine. Yeah.
Mm-hmm. And so 500 milligrams, wrote orally, so PO.
Okay. Yeah.
And it's for we'll give it for 7 days because it looks like it's more severe. His urea rate, respiratory rate is quite high. So for 7 days.
So the start date is today.
Is today, yeah.
Yeah, and the review date?
In 7 days.
In 48
hours. Oh, review days,
48 hours.
48 hours. 48 hours, yeah.
Very good. And so when you said the 7 days one, I have an alternative prescription to oral amoxicillin. It doesn't work as well. But when you say 7 days, you can do that, but you need to write your review date in 48 hours first. So here would be 48 hours. And what you can do when you want to stop it in 7 days, you can go 6, 7, 8, 9, 1, 2, 3, 4, 5, 6, 7, and do this, cross out here. Yeah, so now you have a 7-day prescription of amoxicillin.
I'm sorry, could I just ask a question here? In this sort of situation, when we're prescribing antibiotics, will we have enough time to just check on the BNF? Because I've just checked on the BNF and it said 500 milligrams 3 times a day for 5 days oral. It's for but there's 5 days on the BNF here.
I think you cut out a little bit there. Did you mean to say 500 milligrams for 5 days?
500 milligrams 3 times a day for 5 days. It says on the BNF.
Yeah.
For community-acquired pneumonia.
Yeah, that's fine. So for check on the BNF. You definitely have time to check on the BNF, and you definitely should be checking on the BNF. And last year they also gave us some hospital guidelines, so trust guidelines, local guidelines. And if you have 2, which one would you go for?
The trust guidelines.
Yeah. So the trust guidelines, because it's your locality, the people that they know, something like that. And so go for the hospital ones, the trust guidelines. Yeah, so if the BNF say 5 days, then go for 5 days, depending on if they give you hospital or not. Community acquired pneumonia, if he's coming in, he's having oxygen requirements and so on. Is he have COPD? He might do. Because he smokes 15 cigarettes a day. I would go for IV amoxicillin, but only because it works faster and I'm on rest. So consultants just like to get them ready and out of the hospital if they can. Because if he's taking oral amoxicillin, why does he need to be in hospital? He does not. Okay. Does that make sense? So the reason we're giving him here is that we can give him some IV, but that's not the point. The BNF says oral, fine, we'll give oral, and then obviously sign and write your name and indication. What would you write in this case?
Pneumonia.
Pneumonia.
Community acquired pneumonia.
Yeah.
Yeah. Okay. Acquired, there's no space, so I'm just going to squeeze it in. Expected duration, so we can write here 7 days, or I think someone said 5 days, whichever.
5 days, yeah.
Okay. I'm not looking at the BNF, so I don't know if this is actually right or not, but you guys can check. Okay. Any other antibiotics you like to give?
Probably, yeah. I would also give clarithromycin.
Okay.
Because patients has a severe, I would say it's like his curve 65 out of 2. So clarithromycin.
Yeah.
I can start date. So it will be 500 milligrams orally.
Okay.
And every 12 hours. So we give it at 8 o'clock, and then next one will be at 8 o'clock as well. So we can cross out 22 and put 8.
Okay, that makes sense. And then obviously the start date again up here.
And it's probably 5 days as well.
Yeah, and you have 5 days as well. Review in 48 hours, and you can do the crossing out as per above. Indication, community acquired pneumonia.
Can we use abbreviation, or do we actually have to write down community acquired?
Yes. No, I would be safe and write it in full.
In full.
Yeah, only.
Okay,
I'm being a bit lazy now. Anything else you would like to give?
Oxygen. His oxygen is less than 94.
Okay. Have you asked Mr. Rai if he has COPD?
No, but I think his medical history did mention COPD. Did it?
It did not mention COPD. However, he is on.
I'm not sure.
I think I've seen that COPD there.
Oh, it was it? Okay.
Yeah.
Was there COPD on his history?
No.
Yeah, there was COPD.
There's no.
Okay.
So you should not assume that patients have COPD unless it is proven on a gas. Okay, so if this patient came in, he's 56, yes, he has a smoking history, but until you have the gas results in front of you, you should give a little bit of oxygen anyway.
Okay. Okay, so the date would be obviously the same. Device.
Maybe Hudson mask. He's not that severely hypoxic.
What? Sorry?
I've never seen anyone use a mask.
Pardon?
I would go with the nasal cannula. He only probably needs 1 or 2 liters of oxygen, and that can be safely delivered with the nasal cannula, and that can allow him to eat and drink as well.
Oh, I do, yeah.
So nasal cannula, concentration would be Google.
50%, I think, 30 to 40.
Isn't that is it, I can't remember.
24%.
It's 24. Okay, and then 1 to 2 liters. Target saturations 100. Is that okay with everyone? And then obviously sign and print your name.
I think you can put target 94 to 98 there.
Sorry, just in this case again, the curve it doesn't say anything about the curve score in this and he's less than 65, so I didn't, and he's eating and drinking, so I didn't really think that he'd be that ill that you'd have to give him 2 sets of antibiotics, different types.
His respiratory rate is greater than 30, 32, and his URI is rated as well. So you already get 2 points there. So he definitely needs admission and probably 2 sets of antibiotics.
Yeah.
Okay.
Yep.
Thanks.
Oh, next page. Does anybody else want to try and tell me what to do?
Okay. Yes, so we need to write regular prescription. I think he's taking metformin.
Mm-hmm.
So we write the year, the date and month.
Yeah.
And then the drug, the name metformin.
Great.
Dose 500.
Mm-hmm.
Oral. Signature, print name.
Yeah.
Indication diabetes. And taken in the morning, so 8 o'clock. 8 o'clock we just yeah. Circle. And what else he's taking there? I think he's taking something for hypertension.
Yeah.
It's a ramipril, 5
Which
grams.
one? Yes, so ramipril, 5 grams, 5 milligrams.
Sorry, 5 milligrams.
Oral, start date, yeah. Indication hypertension. Again, in the morning, 8 o'clock, I think.
Okay.
And I think he was saying salbutamol inhalers, but it's not here, I think. Yeah, it's not here.
Okay,
yeah.
So
as why?
Give my screen a second. Okay, it's not okay. There we go. So PRN medications. So salbutamol. I'm gonna write salbutamol dose. Can someone check the BNF as to like how much salbutamol PRN do you give?
I think I was reading about this, and we need to write 2 puffs. I'm not sure if it's you write in a dose. I think 2 puffs.
Yeah, so it's 1 to 2 puffs. The root will be INH. The frequency will be PRN, and the max you can put there is the max is 12 puffs in 24 hours.
12 puffs. And
So, why do we need to give salbutamol to this patient? I'm just not following.
I just checked the screenshot, and I was actually saying that he's got history of asthma and salbutamol PRN.
Okay.
Oh, he does have history of asthma.
This is his normal regular medications.
Oh, it's normal. Okay. Thanks.
The question, if you read the scenario again, it says prescribe appropriate admission medications for this patient. So this patient is in the emergency department. You're going to see him as part of the medical team. You're going to prescribe the medications that he needs on this admission, as well as his regular medications.
Very good. Okay. Thank you.
Okay. Anything else? Are we giving fluids to this chap?
That's it.
Are we giving fluids?
Would it be possible to see the scenario again?
I think he's E plus D, so no fluids, no maintenance fluids.
Is eating and drinking? Yeah, fine.
Yeah.
So don't eat fluids. Happy? Yeah.
Would anyone consider holding the metformin in the scenario?
For a reason.
Oh, he's coming in presumably with chest sepsis.
Oh.
So would anyone consider holding the metformin?
Yes, I think. To prevent lactoacidosis, because of
Yep.
I guess.
You don't have a gas result as well. So you could hold the metformin, but I think if the scenario came out in the exam and if you didn't hold it, it wouldn't be that much of an issue unless they had given a lactate and the lactate was raised. Okay.
How do you hold the drug on the drug chart? Does anybody know? Would you still write it in the regular, would you still write it in the chart, or would you just forget about it?
I think we need to write it down, but we just cross it over, yes? So we just for a record, maybe.
Yeah. So how long would you hold it for? Would you just hold it?
Maybe until you get the ABGs.
Yeah, so in real life, you would be, you would cross it out and go hold, or you could do something like, I don't know, like cross out, and then go review. That's something you would do in real life, but it's not going to come out in the exam, I would say. And also, this is probably better. So hold. Cool. Any questions?
No questions?
So to repeat what you said about the metformin, you said that if the lactate was raised, then you would just withhold it. So could you just repeat that?
So this patient is coming with presumably chest sepsis, yeah? And I don't have a gas in front of me. I don't have an arterial gas. I don't have a venous gas. I don't know this patient's lactate. In order to be safe, I will probably hold the metformin anyway, okay? If the exam does give you the results of an ABG or VBG and the lactate is raised, then you should hold it.
Oh, thank you.
Okay, shall we move on to the next scenario? There's a question. How do we switch antibiotics from oral to IV? You cross out the oral one, you write a new one with IV as the route. Okay. Next scenario, sure.
Yeah. Where is it? Okay. Right. Last one, yeah. It's a long one.
Gosh.
I kind of did it in like increasing difficulty.
Okay, give me a second. Okay, there you go. Who wants to try? No one's got up the confidence yet?
it's quite a long and complicated scenario. Yeah, but you don't have to rush through it. You can take your time and go through everything, because all the information you need is in the scenario.
And you also have the instructions when you go in the room as well, so you can always refer back to it. There's no rush to read it all in 1 minute, like we're making you do today. So you can't share 2 screens.
Yeah, just I can't quite remember the case properly, but it just sounds like acute left ventricular failure. So
okay, should we? This is such a long,
sort of an effective masturbation.
So I'm going to suggest that shall I bring on the scenario again, because it was such a long scenario, and then we can just talk over the scenario for this one.
Can you not share 2 screens at once? No. It says hold control to select multiple windows, but these are my windows, aren't they?
Yeah, so I don't think you can share 2 people's screens at the same time, which is a bit,
It's a shame. Okay.
So he definitely has a heart failure, but there's the yellow sputum, so the sign of infection as well.
So he's coming in with increasing shortness of breath. He's got ankle swelling and fatigue, and he's got a cough that is productive of yellow sputum, and he's feeling feverish. He's got his past medical history there. He's got past heart attack, high blood pressure, high cholesterol. He's on various medications. Yeah. He's allergic to penicillin, and the reaction is anaphylaxis. Yeah. He's also a bit of a smoker. He's an ex-smoker. It's good that he quit, but he's got quite a significant PACIA history. In terms of the observations, respiratory rate is increased, O2 sats are decreased, and he's tachycardic. Yeah, there's some his JVP is raised. He's got an S3, which could be because he's possibly got heart failure, and he's got hepatomegaly. He's got some crackles in the chest as well. He's got proven heart failure with an echocardiogram, and he's got a BNP of 1060. Yeah, he's tachycardic, but his ECG is fine. When you do it on the ECG, his heart rate is only 90 beats per minute, and it's in sinus rhythm. There's no acute ischemic changes, so you're not concerned from that point of view. He's got proven lower lobe consolidation and some features on the chest X-ray, which looks like he might be in fluid overload. Yeah, his U's and E's are there. They look unremarkable to me. Yeah, there's no evidence of AKI. His BNP is raised, his hemoglobin is okay, his white cells are high, and he's got a neutrophilia, and his CRP is very high. So what other things are you thinking of in this patient?
So it's like community-acquired pneumonia, but with a patient sort of acute left ventricular failure, pulmonary edema, so overloaded type patient. So basically, what we'd start with is the patient details, antibiotics as well. I think the CURB score is probably about 2 or 3 here. And he's allergic to penicillin, so you'd have to write that allergic to penicillin. So when you're prescribing the antibiotics, it probably has to be something like doxycycline or clarithromycin, but I check the trust guidelines for that and prescribe it accordingly. And then I would also commence treatment for acute left ventricular failure. So it's just loop diuretic, morphine, GTN infusion, oxygen, because he is also, his SAPs are 90%. He's not a known COPD, so we're looking for SAPs that needs to be above 94%. I give him a 15-litre non-rebreathe mask because he seems quite ill. Yeah, I just position him upright as well. But that's just general. I haven't actually given specifics.
Is it
I'm not sure if it's acute. I'm not sure if it's acute heart failure, left ventricular failure, or is it just congestive? And it's not just left ventricular; it's both heart, right and left. he has swelling in ankle and hepatomegaly, so it's both right and left hearts. So it's a congestive heart failure, and I would say it might be chronic rather than acute.
Yeah, but he's still coming in with possibly a chest infection, but well, most likely a chest infection, which you've got proven there, and decompensated undiagnosed heart failure. So is there any particular type of drug that you're thinking of giving this man?
We need to stop
his blood pressure is
furosemide.
okay. His blood pressure is okay.
Yeah.
Yeah, furosemide. Just give him some furosemide. IV.
Yeah.
Yeah.
It was 40 milligrams, I think, wasn't it?
40 milligrams is very, very sensible. Yeah. Okay. In terms of the antibiotics, we've spoken about that as well. I mean, look at the trust guidelines. Yeah. If you were to go with a macrolide like clarithromycin, would there be any medication that you're thinking of stopping or holding?
Statins. Yeah, the statins.
Yep.
And there was something else.
So would we have to know sources for like in sort of this, like how much furosemide to like prescribe, or could we just once again? I'm a bit worried about that.
Use the BNF.
You can use the BNF, but 40 milligram of furosemide is absolutely reasonable in this patient. Yeah. I think I will probably give him 80 milligram, but don't do that just because his renal function is fine. He can take it. But for you, give 40 milligram. Do you guys know how to write out and prescribe the clarithromycin and hold the statin at the same time?
No.
We show them, Janet?
Sorry, I missed the question. What was it again?
Can we just show them how to prescribe the clarithromycin but also hold statin for that period of time?
Yeah, of course you can. So if say they are on, so imagine this is all filled and oh, let me clear this page. Okay, so imagine this is all filled as well. So let's say they are on atorvastatin. Atorvastatin, yep, and then that's all filled, and then the date and so on. So how long would you give your clarithromycin for?
I think it's 5 days. BNF is 5 days, isn't it? For pneumonia.
5 days is fine. I'm just checking the dose of atorvastatin. Is it 10 mg?
40 milligram.
40, fine. Okay, and then root. So everything is like done. So let's say 5/9, and then we put in the dates. So 5 days, 1, 2, 3, 4, 5. And then I'm just filling in extra dates. So what would you like to, what we would like to do when we are stopping a statin is, actually they take statins at night, don't they? That's fine. We'll just do that. So what you would do is you would cross this out for 5 days. 1, 2, 3, 4, 5. Yeah, and then you put a little box next to the day that you want starting. And then the nurses can like sign on the box, or they'll ask the doctor, is it okay to restart atorvastatin by that point? So when you want to stop a nurse from giving a medication, just cross the bit where they can sign. Does that make sense? So all these little boxes, all these squares, they're for the nurses to sign. And so obviously then you have your clarithromycin up top here, that kind of thing. Is that okay? Is that clear? Yes.
So I've got a question about the previous when we wrote a hold for the metformin. we kind of crossed out and put hold. And when we decide to restart, let's say ABGs came back and lactate is normal, so we want to restart metformin. Do we just need to fill in another box, or we just kind of write over that hold?
No,
write a new messy box.
Right.
So
If you've not crossed out all the boxes, and if there is adequate place to put it, you can just put it. You know, usually what happens is I don't really bother with the metformin. If the diabetes nurses are happy for us to restart, they'll tell us restart it. Or if there's a blood pressure spike, we just give them some insulin while they're an inpatient. But if they've come in with severe sepsis, it's likely that we're not going to stop metformin. I mean, you're not going to start metformin again, sorry, until they're gone home or at the point of discharge.
Okay. But I mean, if ABG comes back and lactate is normal, because we're still waiting for the lactate, and lactate is normal, and we kind of want to not to withhold any longer, so we want metformin to be given. So we kind of.
If they are an inpatient, their blood sugar will be monitored, and they will be given insulin whilst they're in an inpatient. And then I guess the question is, when they get discharged home, do you then put it on the TTOs or not? But then that's
no. You just, the question, sir, is because we're out hold. So I'm just wondering, is it okay just to go and write in the same place, or we need to fill the new one? Or is it, if we write in the same box, is it going to be too messy, kind of thing?
It's
because
not
we fill the dates.
It's not only just messy, it's wrong because you've already held it. So it's better to just try a new box.
New box, right? Okay, that's fine. Okay, thank
you. I have a question about when you're filling out the the things in the station. What happens if you make a mistake? Like, for example, you put I don't know, 40 instead of 50. Like, do you cross it off, put it right beside it? Will they have extra sheets if you make mistakes? Is there only one in the station? I just want to know, because I mean, when I'm writing really quickly, sometimes I make mistakes, so I'm worried that I just don't know how to go around it if I do make a mistake.
There will be plenty of extra sheets in the station. If you do make a mistake with any part of the drug prescription in that prescribing section, you cannot strike it off and write it in the same box. You need to strike off the entire thing and write it again.
And then I'm assuming, or maybe I don't know if this is right or wrong, but for the part where it says regular prescriptions and there's only 3 boxes, would we ever get a scenario where they take more than that and we have to add in extra sheets, or do you think it will only be 3 or less?
There's not enough time, to be honest. They'll probably just give you 2 or 3. I don't think they'll give you more than 3. They just want to see how you transcribe the medications onto the drug chart, and if you know what sections to put the things in.
Okay.
I believe, so I don't quote me about this, but I believe in the exam, the drug chart comes as a little booklet. I seem to remember it coming as a little booklet with the fluids at the back as well. So I don't know if you were here when I was showing my hospital ones. Let me just grab it. It has all the little sections that you need. So it's like a little booklet with lots of different pages. It won't be as thick as this in your exam. I think it's probably 2-3 pages, but I seem to remember it being a booklet, and then you have the fluids at the back of your booklet, I think. But either way, it will be the same sort of style. Okay, does anybody have any more questions? I think that's the end, the last scenario.
Yeah. I mean, it was a real cracker one that I gave as the last one. But if you can work through that, and if you get that correct, you'll be absolutely fine in the exam.
All right, thank you.
Thank you so much for your time. We understand you're working as well, so we really appreciate all the effort you've gone to.
Yeah.
Thank you.
Thank you.
Do it.
Thank you.
Don't worry.
you.
Thank you so much.
Bye.
Thank you.